Okay, go ahead, Ashish.
Hello everyone. Today I am going to present diamond ophthalmic bar assisted modified Dalk in keratoconus patients. I have no financial interest. Generally, we use Dalk to treat the anterior corneal stromal pathologies. An Anwar big bubble technique is the most common technique what we use. But there are some complications like macroperforation or microperforations. This kind of technology, we don't try to use it in such cases like keratoconus with hydrops or dermoid with variable stromal depth. To combat this situation, we tried to develop a modified technique of Dalk using diamond ophthalmic bar. This study aims to do safety and efficacy of the technique of diamond ophthalmic bar assisted Dalk. To do this study, we have done a prospective interventional non-randomized single-arm single-center study with 13 cases of keratoconus with healed hydrop scar and 13 control age-6 matched normal patients came to OPD. Each patient has been participated for 1 year and the entire study was for 1.5 years. As inclusion criteria, we have taken patients with keratoconus with healed corneal hydrops with mean corneal thickness should be more than 200 micron and visual acuity should be more than 1 logmar. As a measurement, we have taken demographic values. Pre-operatively, we have taken best corrected visual acuity and the keratometric reading. Post-operatively, we have taken best corrected visual acuity, keratometric reading, densitometry and abrometric reading. As intervention, you can see first we have done the partial thickness definition. Then the anterior stroma has been dissected out with the help of crescent. Then the mid-stromal corneal emphysema has been done away from the scar and it is dissected with the help of viscodissection, and the last part of the stroma has been polished out with the help of diamond bar. Now, what is the uniqueness of the OB Dalk? Here you can see when we polish with the help of diamond ophthalmic bar, it strips away the stroma and make a smooth predesmatic layer. Even in this case, when we have occurred accidental macroperforation, you can just tamponade it and go on with the diamond bar polishing without any change in the anterior chamber. As a result, demographically, the case and control are age-6 match group. Comparison shows that pre-operative and post-operative there is significantly improvement in the result. The visual acuity over one year of time, it has been improved and it is almost equivalent to the normal patients. The CCT has improved over the time period and it was almost equivalent to normal group of patients after 1 year. The mean graft host thickness was 44 micron. Here the pre-operative Zernicke analysis shows there is RMS total which is 9.7 and RMS Hoya was 4.9. After post-operative it became 5.4 and RMS Hoya was 2.883. The changes in 3rd degree to 5th degree Hoya pre-operative and post-operative shows there is significant improvement except the 5th order pentafoil and trefoil. Changes in Hoya RMS, the 3rd order comma and trefoil shows improvement except the spherical aberration 4th order. After 6 months when there is removal of this suture done, maybe the changes of the cornea reported that. There is a significantly improvement in the densitometric value from 0 to 2 millimeter region of the cornea. The endothelial cell changes, but that is within normal limit. As a complication, we have seen only one patient of macroperforation and high IOP in one case. As discussion, when we have compared with other techniques, it shows that in our technique there is only there is no microperforation is noted, whereas in other technique microperforation was there. When we have compared with our technique with big bubble Dalk and manual Dalk, it shows that the keratometric value, the densitometric value and the abrometric value are equivalent in all of the cases. Only 2 case reports, case series has been published yet. One has been done by us in IJO and one has been done by George D. Kiminos. As a conclusion, I can say that diamond ophthalmic bar Dalk is an excellent alternative in case of such critical case where big bubble Dalk cannot be performed successfully always. The limitation of the study that we have a small sample size and shorter post-operative period, longer time of post-operative should be done. These are my references. Thank you.
Very interesting, and it's very nice that you're able to dissect so well with the Burr. I don't have the confidence to do that. But I think your outcome measures may not be very relevant, is what I feel. Higher order aberrations can be affected by so many factors. And I doubt if this is the outcome measure which is really important. Probably the depth of dissection on an OCT, stuff like that would be more important. Did you measure that, the residual bed thickness?
Yes, the graft thickness was approximately 44 micron.
Okay, yeah, so I think that is more relevant because, you know, suturing technique, everything, so many things come into play, as we all know, even the keratometry values. So I think that is a better outcome measure, and maybe rejection, stuff like that, or irregular, or the best corrected visual acuity final. Yeah, so those are things I think would be nice, but otherwise, nice study, congratulations.
So how consistently were you able to get a thin bed of approximately 44 microns? In every case easily, or
30, the total 30 in 13 cases, what we have got from 33 to 60 micron, I have got the dissection.
30 to 60 microns.
What I have done that till the mid stroma, I have dissected it with the help of visco dissection and combination with the manual dissection. But after that, the posterior part of the lamella, I do not try even to dissect with any manual dissection. Here I try to do polishing with the help of diamond ophthalmic bar, which gives a smooth interface of the PD.
So basically the last 150 microns or so, the posterior stroma, last 150 microns, you try to do it with the Burr. Before that, one can use whatever you suggest,
yes.
But then the last 150 or 100 microns, you do, and you feel that you're very confident it's a safe procedure.
Yes.
And with no perforations, and even
there was a perforation, I could tamponade that place and I can go on with the, and there was no changes in AC depth.
You should try it out, I think, interesting.
So your endpoint, you're using the transparency of the cornea, is it?
Yes. That give a better densitometric reading also post-operatively, which Ashish, is equivalent to
how long would it take you on average to do one, just the Burr bit? How long in minutes? How much time do you actually spend polishing?
It is a bit longer process. Mm-hmm. It takes almost 15 minutes. Mm-hmm. That's the thing what I faced, but rather than having a perforation and changing it to a penetrating keratoplasty, I feel paying 15 minutes is okay.
And this is a standard.
Fair enough.
Yes, the Algar brush too I have used.
Yeah, the Katina. Okay. Great. Wonderful. Very nice talk.